Hello everyone, I am Dr. Himanshu Raval. I am presenting hypertensive supratentorial intracerebral hemorrhage. What is required, surgery or conservative? Let's start with the introduction. Spontaneous intracerebral hemorrhage is defined as bleeding into brain parenchyma without immediately preceding trauma. It may be primarily, as in case of hypertension, or secondarily caused by any other cause, whether it is congenital or acquired. Intracerebral hemorrhage accounts for 10 to 30% of all stroke admission to the hospital, and it leads to catastrophic poor outcome. The worldwide incidence is between 11 to 15%. Aim of this study to assess the clinical aspect and outcome of medical as well as surgical management and its comparison to the existing material and method. The present study conducted at PS Hospital, SVP Hospital, and NHLMMC during the period from December 2018 to December 2020, which includes 100 cases. Inclusion criteria: patient with hypertensive supratentorial intracerebral hemorrhage, which was confirmed on CT. Exclusion criteria: patient with any other cause leading to hyperdense picture on CT was excluded. Results: in this series, the youngest patient admitted was 20 years old and the oldest one was 89 years old with mean age of 57 years. The maximum incidence was seen in 6 decades. In this series, out of 100 patients, 70 were male and 30 were female. The male to female ratio was 2.3:1. The patients were divided into 3 groups based on GCS at the time of admission. 30 patients presented with GCS 3 to 6, 34 patients were admitted with GCS 7 to 10, and 36 were presented with GCS more. 50 patients were treated medically, and outcome of this medical treatment we can see in this below mentioned graph, which was suggestive of the favorable outcome is more pronounced in patient which were presented with GCS more than 10, and the death or unfavorable outcome is more in case of patient which were presented with GCS less than 10. Result we can found in whether we treated patient with surgical management or just external ventricular drain. The discussion: in this present study, patient's outcome was graded according to the activities of daily living score. The total mortality was 50% and favorable outcome seen in 38% of cases and unfavorable outcome seen in 12% of cases. Similar observation in terms of mortality which was made by Imniski in his series of 145 patients. The Damija and Perth Community Stroke Registry has overall fatality rate around 35%. Imniski and W. Clock suggested that surgery should be considered in cases with progressive neurological deficit, functional impairment lasting longer than week, and development of intracranial hypertension. Surgery is not indicated in case of deep coma, absence, or regression of neurological deficit, it is stated. This trial concluded that the early surgery for ICH is feasible. A modest early mortality benefit for surgery is possible, but long-term benefit for surgery was not established. Similarly, in our study, we have found that early surgical intervention in patients with ICH without intraventricular extension with impending neurological deterioration would be beneficial. Cases with intraventricular extension in hematoma volume more than 40 cc showed high mortality in both surgically and medically treated patients. It is seen that patient having poor GCS at the admission has poor after the treatment. On the basis of current study and its comparison with existing study, we can conclude that patient having initial GCS between 11 to 15 with no sign of raised ICP should be treated with medication to lower blood pressure and other supportive measures. In patient with deteriorating consciousness, signs of raised ICP and uncal herniation, surgery is indicated. Early management with precise intervention, whether it was surgical or medical, it results in better outcome. Mortality and morbidity is higher in the patient with GCS less than 10 at the time of admission. So it is the most important criteria. Here are the references. And thanks for the listening. Thank you.